හිරු
මේක සර්.
මේ
ඔව් සර්.
ඊට පස්සේ ෂෝට් කෙස් එක කරනකොට ඔයාගේ ස්ක්‍රීන් එකේ වීඩියෝ එක ප්ලේ කරනවද මොකද කරන්නේ?
ඔව් සර් මේ මම නෙවෙයි ෂෙයා කරන්නේ සර් මේ ගිහාන් ෂෙයා කරන්නේ.
හරි
මේ ස්ක්‍රීන් ෂෙයා ඔන් කරන්න වෙනවා සර්.
රයිට් ඒක එතකොට කරමු නේද? හරි
ඔව් සර්.
හරි ඕකේ හරි
Good evening, sir.
පටන් ගමු. good evening
The
උපේක හරි කියමු.
patient is Miss W.D. Sandamali, who is a 22-year-old unmarried lab technician from Borella. She was presented with shortness of breath for 4 hours duration. And she's a diagnosed patient with type 1 diabetes mellitus and hypothyroidism who was in her usual health, and she has developed acute onset difficulty in breathing around 7 a.m. on 2nd of October while getting ready to go to work. Shortness of breath was gradually worsening, but she could speak in sentences. Preceding that, she has felt dizziness and has slept for 2 hours. She was suddenly waken up from sleep, gasping for her breath, and has experienced visual blurring. There were no significant preceding triggering factors or relieving factors for the shortness of breath, and she haven't has experienced similar episodes before. Mother has noted that her breathing pattern was abnormal and rapid, but no preceding excessive urination, excessive thirst, or abdominal pain was there. No faintishness or loss of balance or loss of consciousness was detected. She was not having any difficulty in breathing on lying down, chest pain, or feeling of her own heartbeat. No abdominal or ankle swelling was detected, and she complains of recent loss of appetite, but there were no loss of weight. She is having an exertional dyspnea and can climb only up to about 30 steps without a difficulty, where she lowering pain while on long distance working. And but there were no past history of ischemic heart disease, congenital or valvular heart diseases, but she is having a family history of ischemic heart disease in her second degree relative. And there were no symptoms suggestive of a respiratory tract illness such as cough, sputum production, sore throat, or nasal congestion. There were no wheezing episodes, and there weren't any diurnal variation of the shortness of breath work, sir, and she was not having any history of asthma also. There were no occupational exposures to the drugs or chemicals, and there were no features suggestive of connective tissue disorders such as oral ulcers or loss of hair or joint pain, and no associated fever, nocturnal sweats, or contact history of TB, and there were no coughing up of blood or vomiting of blood, and no malaise or esophageability, which is suggestive of anemia. And she has been admitted to the EDU preceding this shortness of breath, and on admission her capillary blood sugar level was 580 milligram per deciliter, and several blood and urine investigations was done there, and she was managed with oxygen, normal saline, and insulin according to the mother. And sir, regarding past medical history, she was diagnosed with type 1 diabetes mellitus 12 years back when she was 11 years old, and she was apparently healthy until the August 2008, and for about a 1 week of period she was having generalized malaise, excessive thirst, and excessive passing of urine, lack of energy, and increased sleepiness. A marked loss of weight was noted by mother during that period, but it was not measured, and she has passed a large amount of urine in the bed at night unconsciously for 2 consecutive days, and she was previously dry by the day. So the parents have seek medical attention from a general practitioner, and their blood sample and a urine sample was checked, and initial random blood sugar was detected to be 660 milligram per deciliter, and she was admitted to LRH. Up until the 15 years of age, she was managed regularly at clinic follow-up at LRH, and currently being followed up at NHS diabetic clinics. And there has been several previous hospitalization due to hypoglycemic and as well as hyperglycemic episode at least 2 times per year, sir. And she is being regularly followed up at NHS diabetic clinic, and 2 monthly follow-ups and diabetic center at Rajagiri also, sir. She is
Okay.
regularly screened for diabetic complications, usually around 3 months and annually also. And
Mm-hmm.
up to now, no macrovascular or microvascular complications were detected, but she is having recurrent urinary tract infections and complaints of intermittent claudication also.
Mm-hmm.
And uh, initially, she was started on metformin 250 milligram, and it was increased up to 500 milligram per day together with insulin, sir. And after about 4 years of treatment, the treatment was converted only to insulin, where she was currently on soluble insulin 20 unit main, 20 unit noon, and 8 unit Vesper, and also with isopain insulin 15 unit main and 6 unit at 6 p.m. And
Okay.
her glycemic control was difficult and sometimes required very high doses of insulin also. Her last HbA1c level was 14.2, sir. And she has a good knowledge about the technique of injecting, storage, and
Mm-hmm.
identification of expired insulin. She injects by herself, usually to the paraumbilical and deltoid regions alternatively. Anterolateral thigh is avoided due to pain. She stores insulin in the drawer compartment of the refrigerator and usually inject half hour before meal. Insulin is provided either from NHSL Diabetic Clinic or Diabetic Center at the Rajakiria. She is complaining of some pain and tightening in injection site as she is afraid of pain. So sometimes whenever she gets the pain, she avoids injecting insulin. And she has an insulin pen which is only used when she is going on some long long distance journeys. And according to her and mother, she is adherent to the diabetic diet given to her, and she is having a
Mm-hmm.
glucometer with continuous supply of strips. Usually she checks CBS, and it was sometimes varies between 130 300 milligrams per day, deciliter also. But according to her, both her mother and her is having a good knowledge about the disease. Otherwise, the rest of the systemic inquiry was not significant, sir. Regarding past medical history, other than this type 1 diabetes mellitus, she is having hypothyroidism for 10 years duration
Okay.
and detected with the recurrent episode of urinary tract infections. Past surgical history and the allergic history was not significant. Regarding the drug history, she is on thyroxine 200 milligrams and
My
isophane and sorry,
thyrox
sir,
200 micrograms, you mean?
sorry, micrograms, and as a soluble and isophane insulin.
Right.
And she has attained menarche at 16 years of age and currently having irregular cycles, where her last regular menstrual period was on 21st of August. And she was born to non-consanguineous parents, and there were no previous family history of diabetes mellitus, but after she has been detected with type 1 diabetes mellitus, her family members was screened, and her younger brother was detected to have type 1 diabetes mellitus,
Hmm.
who is 18 years of age
Hmm.
now.
Hmm.
And regarding the social history, sir, she is living with her father, mother, and two brothers, and she has a good family support. And she is working at a Durgan's Lab phlebotomy section, and she is earning around 25,000, which is adequate for her needs. And there were no restriction to the job duties. She can inject insulin at the working place also. There were no
Okay.
difficulties in that. And her she's sorry, sir.
No, that's fine. Continue.
She's educated up to A levels.
Yeah.
She's educated up to A level. She can manage her normal lifestyle and having a good knowledge about the diabetes and the complications. But worries about her future with this recurrent hospital admissions and the poor glycemic control. And she is the closest hospital is National Hospital of Sri Lanka. Can reach by 15 minutes, but there is no vehicle at home. They need to hire a vehicle for the admission. On my examination, sir, she is BMI of
Yes.
21.46 kilograms per square meter, and she's febrile, not icteric, but she's pale. And the other significant findings in the examination was injection sites at the abdomen with hypertrophy. Otherwise, there were the abdominal, CVS, and respiratory system examination was normal, and she was uh, hemodynamically stable with a regular pulse rate of 80 beats per minute and a blood pressure of 110 by 80 mercury millimeters.
Okay, right. Okay.
That is the summary.
That's fine. Fundus examination was okay. No retinopathy. Upeka. Upeka.
Yes, sir.
The fundus examination karada.
Yes, sir.
Mateka. The
It's a fundus examination I did. According to my examination, there were no significant findings, sir.
No significant. Okay, fine. Upeka, could you give us the problem list in this patient to start off, and we'll just generate a discussion from that.
Sorry, sir.
What are the problems that you have identified in this patient? So you can classify them: acute medical problems, non-medical problems, and also the long-term problems. So what are the problems that you have identified?
Regarding the problem list, sir, the acute medical problems were she was presented with the diabetic ketoacidosis episode, and currently the urine output was reduced, and she was having shortness of breath. The chronic medical problems was type 1 diabetic mellitus with poor glycemic control, and I suspect whether there is peripheral vascular disease, and she was having anemia on the blood reports, and having hypothyroidism, and she was having delayed puberty and irregular menstrual cycles. And problems are for the
so she has delayed secondary sexual characteristics.
She has yes, she has attained menarche at the age of around 16 years.
16. Got it.
Yeah.
Continue.
Irregular menstrual cycles are there, sir.
And what else were you trying
Non-medical
to say?
problems are she had to take leaves regularly for medical follow-ups, and may affect the job also. She has recurrent hospitalization due to hypoglycemic and hyperglycemic episode, and she is a bit worried about her future with this disease. Those are the problems that was identified.
Okay, Upeka. Right. Thank you for that. So again, that was well done. So that was a good comprehensive history and examination, which is good. The problem list, a few comments about that, Upeka. Don't mention diabetic ketoacidosis as a problem unless you're absolutely sure about it. Because sometimes the examiner might want you to discuss differential diagnoses of acute shortness of breath. I know that this is probably a presentation of diabetic ketoacidosis from the way you presented it, but don't restrict yourself in the problem list. You can say the patient presented with a episode of acute shortness of breath and hyperglycemia, which is probably diabetic ketoacidosis. Eka, you can mention, but don't restrict your discussion too much. That might work against you. Okay? Because the examiner might want to discuss a differential diagnosis of acute shortness of breath. So don't use that very restrictive terminology when you're presenting. Right? But apart from that, I think you had got most of the other key problems. I'm a little interested to find out why was she given metformin at the time of diagnosis? Was there a particular reason for that?
I also couldn't find a reason, sir. I obtained her records, previous clinical clinic book, and initially she was given together with insulin at the first presentation.
That's rather unusual, I would say, because I don't think there's really much doubt about the diagnosis of type 1 diabetes in this patient, unless of course she was obese and they were suspecting some sort of, there are some rare genetic things where you can have both insulin resistance and type 1 diabetes, but it doesn't seem like that either. එහෙම මොකක් හරි suspicion එකක් තිබුණාද? There are some rare sort of lipohypertrophy or lipodystrophy syndromes that can be genetic. But don't worry about that. It doesn't make sense because I can't really figure out why she was on metformin. ඒ ගැන කලබල වෙන්න එපා. Don't worry about that. Right. So now in this case, if you get this case for the exam, now we have already discussed a patient with diabetes and I have gone through the principles of management and the sort of questions that can be asked from you at the exam. So if we focus our attention purely on this patient, let's sort of see what questions can be asked. Now, the first thing, obviously, is they will ask you invariably about management of diabetic ketoacidosis. Definitely, if you get this case for the exam, they will ask you that question. Now, I will discuss this in your medical emergencies class somewhere next week. But just to give you a broad sort of overview of management, um, you have to talk about some key principles of management when you talk about DK. Harida, touch on that only today, right? But we'll go into depth in your emergency medicine class. Now, if somebody asks you about, yeah, if somebody asks you about the principles of management of diabetic ketoacidosis, there are a few things that you have to mention, right? And I am sure that the examiner will ask you about this in this particular case. So what are the principles of management? All of you should know what the definition of diabetic ketoacidosis is, okay? And obviously, it is self-explanatory, okay? The title of or the diagnosis gives you what it is. So diabetic ketoacidosis is frequently seen in type 1 diabetics, very occasionally seen in type 2 diabetics who have very advanced disease, right? That is very important, right? So diabetic ketoacidosis you associate with type 1 diabetics. Occasionally, you do see it in type 2 diabetics with very advanced disease. Now, the reason for that, have a long history, say 30, 40 years of type 2 diabetes, they essentially have pancreatic failure. Okay. Now, you know that type 2 diabetes is mainly insulin resistance, and that's what you see. But when they have very long-standing disease, the pancreas burns out and it essentially transforms into insulin deficiency as well. Okay, towards the end of the disease, say if you have the disease for several years. So initially you have insulin resistance, but with time the pancreas fails. Okay, and so in patients who have very advanced, poorly controlled type 2 diabetes, they might present to you with diabetic ketoacidosis, but it's almost otherwise associated with type 1, right? And they have hyperglycemia, okay, acidosis, ketosis. Okay, so you have hyperglycemia, acidosis, and ketosis. Now, ketone bodies, it's ideal if you can measure ketone bodies in plasma, okay? But the test is expensive and it is not freely available in our part of the world. We can check ketone bodies in urine, okay, which is less sensitive, but that's the only thing we have. So ideally, you should demonstrate a plasma ketosis or plasma ketone body positivity. Or if you don't have a plasma ketone body, it will be urine ketone bodies. Okay. So that is how you establish a diagnosis of diabetic ketoacidosis. Now, once that's done, there are several principles. First and foremost is fluid resuscitation, right? So whatever you talk about diabetic ketoacidosis management, you have to say that your first um, principle of management is fluid resuscitation. Okay. If the patient is in shock, you need to manage the patient with boluses. Okay. Or otherwise, if the patient is not in shock, remember that these patients are generally about 3.5 to 4 liters fluid deficient. Okay. Even if they don't present with shock, they are generally about 3.5 to 4 liters fluid deficient. And fluid replacement, fluid resuscitation forms one part of the management plan. I will talk a little bit more in depth about exactly how much fluid you give and so on next week. So fluid resuscitation is key. Now, The second important principle is potassium replacement. Okay, potassium replacement. Now remember, there are two important things you need to remember. We now know, or we've known for several years, that patients with diabetic ketoacidosis are actually potassium deficient. Okay, their serum potassium levels might be normal, but they're actually potassium deficient. Okay, because their intracellular potassium might be low. So that is one thing that we know, right? So that DKA patients are actually potassium deficient. Right. The second thing is, remember that in a little while we talk about insulin therapy in DKA. Insulin therapy lowers the potassium, the plasma potassium, okay, because it drives the potassium into the cell, right? So generally, patients with DKA are in a state of potassium depletion, right? Are in a state of potassium depletion, and you will also notice that from the blood or the plasma. Right. So this is the second principle. So potassium replacement. Again, we'll talk about more details next week. So now two things. The third thing is insulin therapy. Remember, very importantly, you need to say insulin therapy must be a soluble insulin as the preparation, and should be as an insulin infusion. Is infusion. And this should always, and I stress the point of that, and you need to tell the examiner that throughout the very important. Hari. And the ways you titrate it, we'll discuss. But remember, even in a long case, specifics are there. Going on a principle. So, what as a house officer, what are the things that you need to do or look into, right? So, make sure that you do fluid resuscitation. That's your primary management objective or your principle. Number two, you are basically worried about potassium and you need to replace potassium, replenish potassium. And when you start insulin infusion, the potassium is going to drop further. So you need to be careful. Number three, your insulin therapy should be soluble insulin, always via an infusion pump. Right? Do not give it in any other way. It's extremely dangerous. Okay. Another subsequent point on insulin therapy is if the patient is already on a long-acting or an intermediate acting insulin regime, do not stop that. Right? Do not stop that regime while you are on the infusion. So basically, any long-acting insulin should be given. Okay. And we have this wrong idea that while the patient is on an insulin infusion, no other insulins can be given. Okay, that is wrong. If the patient is on a long-acting insulin, that should be given as usual. Okay, it is important. Right. So these are three important principles. The fourth important principle is acidosis does not need active correction. Okay, acidosis does not need active correction. In most, it is dangerously low, say for example, less than 7. So that is important to mention. And when you correct the fluid and you give the insulin, the potassium and all of that, the acidosis corrects itself. So you don't need to give bicarbonate or acidosis. So those are the four pillars or the four principles of management of a patient with diabetic ketoacidosis. Okay, so fluid replacement and watch out, monitor the patient's acidosis. It corrects itself when you correct the other parameters, the fluids and the parameters. Now I'll add another principle to this 4, and that is to say that you have to monitor the patient very carefully. Okay, monitor the patient very carefully. So you need to monitor the patient's blood sugar, right? Ideally every 30 minutes to 1 hour. Do blood gases to monitor the pH. The frequency you can decide, right? There is no set rule. You have to do it every hour. Based on the initial pH, you can just keep an eye out on the pH and do regular blood gases. Ideally, you should monitor plasma ketones, but that is not free available because of cost. Okay. Ideally, you should monitor plasma ketones, but in Sri Lanka, you can't do that in the government sector hospitals because it's an extremely expensive test. Okay. But we go by the blood glucose and the VBG findings. You don't need to do arterial gas, just a venous gas is fine. Okay. And you can just look at the trend of the pH. So those are your principles. So in this case that Upeka has presented, that will be a major topic of discussion. They will ask you, right, what what principles as a house officer or as a junior doctor, what are the principles that you institute when you're managing decay? So you talk about fluids, you talk about potassium, insulin, and acidosis. And you also say that as a house officer, I will also monitor this patient very carefully, especially the blood glucose and the pH. In addition, you need to obviously monitor their vital parameters and their urine output, which you would do in any emergency anyway. So those are the things that you need to discuss. So that is the first thing. Right. Now, the second interesting thing about this case, and I will sort of talk to you a little bit more detailed about that as well, is this patient's very poor glycemic control. Now, you can see that very clearly this patient is off target, right? And you know that the HbA1c of 14.2 is unacceptable for this patient, right? That is unacceptable, and is you're asking for trouble with that HbA1c. Now, Upeka, what now you've taken this history and you've sort of had spoken to this patient and her mother as well. Why do you think she has poor glycemic control? What are the reasons that could be contributing to that? And this is going to be an obvious
Sir,
question that you're going to be asked.
sir, I think that though they say that they are having a very good compliance to the insulin, I noted that she is injecting herself, but she is very afraid of the pain, even when injecting something or putting cannula. So she might not be injecting it regularly, sir.
Yeah. So that is
But on
frequently the
inquiry, she
problem.
says that she is well compliant.
Right. So and that's fine. So this we often see patients. They tell you, right, I'm taking my insulin single day. I'm not missing a single dose. But the fact that there are like you in this patient's history, she's been in and out of hospital, right, with hyperglycemic episodes, and there is sort of twice a year she's in hospital. Her HbA1c is 14.2. And also, Upeka mentioned that her CBS fluctuates, and she's measuring that on occasion, fluctuates from 130 to 300. So this is three objective evidence, facts of evidence that we can say patient is probably not compliant therapy. Okay, so that is something that you need to highlight. So she's in and out of hospital. This time she's presented with DKA, and she has hyperglycemic episodes every 2 months, or twice every year, sort of. Her HbA1c is more than twice what she should be. And then also her blood glucose, her capillary blood sugar fluctuates from 130 to 300. So all of this is evidence to say that she's not compliant to insulin. And as Upeka mentioned, probably this originates from the fact that she's scared of needles. Um, so how would you address that problem? Is something that you need to think of when you present this case, right? So how would you address this problem? Now she said she has a pen, insulin pen. So maybe we can encourage her to use that a little bit more, because actually the pen, this needle is much smaller when you use the pen, right? So that is something that we can maybe look into. Right now, I'm going to just discuss a little bit about insulin therapy in type 1 diabetes, which is something that we haven't discussed before. Now, remember, so insulin therapy in type 1 diabetes, the principles are similar to type 2, where, as I told you, when we're talking about type 2, the main principle is you have to provide the physiological pattern of insulin. So that is very important, right? You have to provide a physiological pattern of insulin, right? And that includes multiple daily injections, right? So you are providing the pattern of physiological pattern of insulin. Now, what is the physiological pattern of insulin? You have a basal insulin. Basal insulin. Now, in order to provide the basal insulin in a type 1 diabetic, you can give a long-acting insulin. Long-acting insulin, right? Now, those days we used to use lent insulin, but that is, I haven't seen that be used for a long time. Some patients might still be on it, but I know they manufacture it even still, right? So that is, but now we have newer, long-acting insulin preparations, right? Now, what are these insulin? What are these insulin preparations? කියලා ඔයගොල්ලෝගෙන් අහන්න පුළුවන්. හරි? So what are the long-acting insulin preparations? Glargine is one. Okay. Detamere is another one. So glargine, detamere, right? And there's another one called degludec. Okay, degludec. Okay, so detamere, glargine, and degludec. Now, these are long-acting insulins, which actually give you a cover for 18 up to 24 hours, right? So that gives you that cover, that basal cover. So because our main principle is to mimic the physiological secretion of insulin in your body, all type 1 diabetics should be on a basal insulin. And preferably, this basal insulin would be one of these long-acting insulins, detamere, glargine, or degludec. Okay, that is what gives you that basal cover. Now, the problem in Sri Lanka is these long-acting insulins are not freely available, right? So what we do is we give them twice daily intermediate acting insulin as this patient is on. Yeah, as you can see, Upeka very nicely presented the regime that this patient is on. So you can see that this patient is on a twice daily intermediate acting insulin. එහෙම නේද උපේක? What? How much of that is she on?
Yes, sir. She on.
How much in the morning and how
She's
much in
on
the evening?
soluble insulin, sir, in the morning, 20
No,
units,
I'm talking about the
and
basal cover, Upeka.
in the
So
noon,
basal cover.
20 units, 8 unit in the vesper. Sorry, sir.
So she's getting an intermediate acting insulin twice a day, nේද? Upeka?
Hello?
Hello, Upeka. So she's getting
Sorry,
an
sir, I couldn't hear.
No, that's okay. She's getting an intermediate acting insulin twice a day. Am I right? That's okay. There seems to be some connection problem. Hiru, ඇහෙනව නේද කියන එක? Hi. Right. So I don't know whether Upeka can hear us, but basically, so if you cannot give one of these long-acting insulins, so the advantage of those is you can give once a day injection. But because we don't have these long-acting insulins freely available in our country, we use this twice daily intermediate acting regime. හරි ඒක තමයි මේ patient යන්නේ. So first principle, you give the basal insulin. Then, so this can be given with a once daily long-acting insulin preparation or a twice daily sort of intermediate acting insulin preparation. එහෙම දෙන්නත් පුළුවන්. Usually, a type 1 diabetic to start off with will need about 0.2 to 0.4 unit per kg per day, right? 0.2 to 0.4 unit per kg per day. And this can actually increase up to around 1.5 unit per kg per day as the disease progresses. Okay. Uh, so generally 0.2 to 0.4, but it can increase up to 1.5 per day. So you have to calculate the dose. If you're giving a intermediate acting insulin, you give two-thirds of that dose in the morning and one-third in the evening. Right? So the total dose is, as I told you, if it's a long-acting insulin, it's a once-a-day shot, no problem. But if you are giving an intermediate acting insulin, like we are doing for most of our patients, you give two-thirds in the morning and one-third in the evening. That is the way you go. Right. Right. Then, then what you do is for the next principle is you need to, as I told you, the underlying main principle is you need to match the physiological insulin secretion. So what you do is then you give the basal, that's fine. Then you give on top of that mealtime insulins and injections of soluble insulin or rapidly acting insulin analogs. Right? So those are the two types that you can use. ලොකු වෙනසක් නෑ ওই දෙකේ. Soluble insulin, the usual insulin that you all know. There are rapidly acting insulin analogs which are a bit faster acting, right? You can use them at meal times. Then මෙන්න මෙහෙම සෙල්ලමක් තියෙනවා, right? If the patient is educated enough, you can actually teach them to adjust this insulin, the soluble insulin, according to their meals. Okay. Okay, there are various ways of calculating how much insulin they should get per meal. There is something called carbohydrate or calorie counting. Right? ඒතර patient කියලා දෙන්න පුළුවන් according to their diet how to adjust their insulin dose. This is the soluble insulin dose that you give with meals. Right? You can do that, and obviously මෙහෙනම් කොලටම් වගේ එහෙම තමයි කරන්නේ. But even in Sri Lanka, if the patient is educated, you can actually train the patient to adjust the insulin based on their meals, right? And the amount of carbohydrates they take in their meals, you can make them adjust their own insulin. But that is obviously in Sri Lanka for only a selected group of people who are well educated and know how to do that, right? For the vast majority of people, the doctor would adjust the dose for them based on their glucose measurements, right? On their glucose measurements. All right. So that is how you give insulin to a type 1 patient. Basal insulin first, a long-acting insulin, or twice daily shot of intermediate-acting insulin with the soluble insulin with meals. Now, another way of giving insulin is to use pre-mixed insulin or mixed-starred insulin. But the problem is that is going out of fashion now because you can't chop and change it according to the patient. The flexibility is less. But සමහර වෙලාවට දැන් patient ගොඩක් injection වලට අකමැති කෙනෙක් නම්. Now for example, this patient is getting 5 injections. So this patient is scared of injections. So part of your management strategy might be to reduce injections. And that might actually help in this patient. ඒ වගේ අයගේ you might use 2 times a day injection of pre-mixed insulin. 2 times, sometimes Katulandasa uses three injection also. ඒක වෙනස් වෙනවා based on the patient. So that is a third line option. So remember, what are the principles of insulin in type 1 diabetes? මේවම තමයි type 2 අයටත් අදාළ වෙන්නේ. In type 1 diabetes, basal cover has to be provided. Basal cover could be given with long-acting insulin once a day, like detamir, glargine, or degludec, right? There are some newer ones also. That gives you a 18 to 24 hours cover. If you don't have access to these insulins, use intermediate-acting insulin twice a day injection. 2/3 of the dose in the morning, 1/3 in the evening. Total dose generally maximum comes up to about 1.5 unit per kg per day. Starting dose would be 0.2 to 0.4 unit per kg per day. Then you can actually train the patient in some instances to give the next talk. That is a soluble insulin with meals. So either soluble insulin or rapid acting insulin with meals. And you can train the patient to calorie or carbohydrate counting and adjust the dose as well if the patient can do that or has the ability to do that. Right. All right. Now remember, with developments in medicine, there are some new ways of giving insulin in type 1 diabetic insulin pump. Okay, so that's a patient has a sort of self-fitted device, which is an insulin pump that automatically detects the sugar and gives the relevant dose of insulin. හරිද? ඒක ලංකාවේ කරනවා in again a very selected group of patients, right? Insulin pump. This is actually very useful in people who have sort of poor compliance or are very sort of up and down insulin levels, they may glucose levels, but again expensive, not used in Sri Lanka yet. Then මම ඔයගොල්ලන්ට තව කියලා දුන්න අලුත් ඩෙවලොප්මන්ට් එකක් තමයි අර මේ interstitial glucose එක බලන්න පුළුවන් gadget එකක් මතකද කිව්වා. So ඒකත් පොඩ්ඩක් when you're talking about type 2 diabetes, I mentioned a gadget, right? That's a special thing. It's a smartphone app එකක් වගේ මෙතන කැලලක් අලවනවා and the patient can self monitor their glucose levels, right? So that is something which is again new and it's actually quite good. හරි මේක මරු ඇත්තට මේකට දැන් ඔය ඇන බලන්න අවශ්‍ය නැහැ. ඒකින්ම බලන්න පුළුවන් smartphone app එකේ patient can monitor their glucose levels. So that is again a very good development, but it's expensive. හරි? Okay. So it that you need to know about insulin therapy. So for this patient that we've just discussed, I think going forward you need to address the patient is not compliant and we need to improve the patient's compliance. So two practical ways of doing that might be maybe switching to a pen and something that causes less pain, right? The other option might be to actually reduce the number of injections a day, right? And that is what I told you, we might actually consider either a twice or 3 times pre-mixed insulin. Why this pre-mixed insulin or mixed insulin regime is not preferred these days is the flexibility is difficult. To change the doses is slightly more difficult. But advantage is it's cheap because it's freely available for us in the government sector, and also it involves less number of injections. So those are the possibilities that you can consider in this space. Okay, so that's the second problem. Right. Now the next problem is we talked about the patient was pale and was anemic. Now that's an interesting one. Okay, why is the patient anemic? Right? Why is the patient anemic? It's a very interesting question. Now, Upeka, are you still with us?
Yes, sir.
Okay. So, Upeka, what sort of anemia does the patient have? Is it a microcytic anemia? What sort of anemia is it?
Sir, A1C was 11.5, sir. HB was 11.5, but blood picture was available.
What is the MCV?
Sorry, sir.
What is the MCV, Upeka?
Sir, I haven't noted.
What is there in the blood picture? That's fine.
Second
That's okay.
appointment.
What is there in the blood picture? Come on, that's okay. So let's do a broad discussion of that. Now remember
sir,
that
iron studies was available. And serum iron level was 22.7, which was low. And total iron binding capacity was 366, which was in normal level. And iron level was 7.5. And iron saturation was 6.19, sir.
Okay, so there is evidence of iron deficiency in this patient. Now, remember that type 1 diabetics, anemia can be due to obviously a range of reasons. But the anemia could actually be type 1 diabetes. And if you say that, patas, you will get a whole load of marks. Now, obviously you have to go through the common causes like dietary deficiency, right? Which is obviously very, very common, right? In a female having irregular menstrual periods, menorrhagia-induced iron deficiency due to blood loss, very possible. Right? So dietary deficiency is important cause. Menstrual blood loss is a very important cause. But you always have to consider, because this is type 1 diabetes, a possibility of celiac disease. The ඕක විභාගෙට කිව්වොත් people will be impressed, right? Because now celiac disease in Sri Lanka is uncommon, right? It's not a very common thing, right? It's much more commoner in the West. But because this patient has type 1 diabetes, and all of you know that type 1 diabetes is associated with other autoimmune processes. Now, this patient already has hypothyroidism, which I assume is autoimmune, sort of a Hashimoto's type thyroiditis. And we very well know that type 1 diabetes is associated with celiac disease, and that can cause iron deficiency anemia due to poor absorption. So that is a possibility that we have to consider in this patient, right? And I would recommend you to read up a little bit about the sorts of tests that you would do to diagnose celiac disease. There are antibody tests, and also read up what you would find on the biopsy, right? Usually you do a small intestinal biopsy or a duodenal biopsy. What would you find on that? And also what antibodies you do for diagnosis of celiac disease. Becca, was there a consideration of celiac disease in this patient?
I'm not sure about that, sir.
Not sure. That's okay. Don't worry about that. Don't worry about that. Yeah. But ඔගොල්ලෝගේ DD එක දැම්මොත් people will be impressed, and that shows that you're thinking. So you can say the anemia in this patient could be directly related to her type 1 diabetes. And because type 1 diabetes, it's mainly an autoimmune process, patient is at risk of developing other autoimmune diseases. Evidence in point, the patient has probably has Hashimoto's already. The anemia could be related to celiac disease. That is a possibility you need to consider. Obviously, the anemia could be due to other causes. Common things remain common. Dietary deficiency remains common. Worm infestation remains common. Menorrhagia or menstrual blood loss causing anemia, that is common, right? So you need to consider all those common possibilities as well. But remember, because this patient is type 1 diabetic, then the possibility, could this be a celiac disease causing anemia, needs to be discussed. Okay, fine. So those are the things that I actually wanted to discuss specifically in relation to type 1 diabetes. It's a very good case actually to discuss about insulin therapy, diabetic ketoacidosis, and also anemia in diabetes. So these are some specific things that we were able to discuss from this case. So I think we've now covered basically everything you need to know about type 2 and type 1. This one small thing that I might have missed is about now, about hypoglycemia in diabetes. That's an important topic that you need to know, and remember that your patient, this patient also has had several episodes of hypoglycemia. You need to know what are the causes of hypoglycemia in diabetes. Right? Now remember, the commonest cause of hypoglycemia in diabetes is iatrogenic. Right? It is either related to insulin therapy or to medication. Right? It's the most common cause of hypoglycemia is that. Right? And it's either insulin related or medication related. And we've already discussed that the highest risk of hypoglycemia is seen with sulfonylureas, right? Sulfonylureas, that is one of the commonest causes of hypoglycemia, right? The second commonest cause of hypoglycemia would be related to renal insufficiency. Based on my experience or what you've seen in was, by far the commonest cause of hypoglycemia is medication induced. There is no doubt about that. And frequently it is due to a mismatch between medication, diet, and exercise. That is what triggers it in almost 90% of cases. Right? But then you see, also in patients with advanced complicated diabetes, renal impairment contributing to hypoglycemia, and that is due to a problem with clearing or metabolizing insulin. So that is something that you see as well, right? Okay. So ඔය දෙක අනිවාර්යෙන් කියන්න. There are some other causes of hypoglycemia in diabetes which you might be interested in knowing, right? And this is again seen in advanced sort of end-stage disease. One is, these are rare but important, autonomic neuropathy, autonomic instability, autonomic neuropathy promotes hypoglycemia in diabetes, right? So that is one thing that you need to know, right? When you have autonomic neuropathy, the hypoglycemia sensing mechanisms are abnormal, right? And this actually creates a vicious cycle that promotes more and more hypoglycemic episodes. Okay, that is something that happens. Okay, fine. So autonomic neuropathy can actually promote hypoglycemia, right? The next thing is, when you have very advanced diabetes, in the pancreas, you have alpha cells which produce glucagon. Alpha cells produce glucagon. And when you have very advanced diabetes, this affects the glucagon producing alpha cells, and those start to fail as well. Right? Glucagon is one of the key defenses against hypoglycemia. Right? It actually is very important in raising your blood sugar in hypoglycemia. Right? So when you have glucagon deficiency, that affects your glucose levels as well. So that is another reason why these advanced, poorly controlled diabetics become hypoglycemic. Right? So as an undergraduate, if you know those things, that is perfectly fine. Okay, so you need to mention that if you have a hypoglycemic patient, the commonest cause of hypoglycemia is medication-induced, insulin or sulfonylurea-induced, 90-95% of cases. Then the rest of the you need to discuss about renal insufficiency as a possible cause, and also going on to rarer causes like in advanced diabetes, the autonomic neuropathy might promote it. Plus, you might need to also think of pancreatic alpha cell failure because of the whole pancreas is destroyed and it's not secreting any glucagon. Glucagon is one of the key things in when it comes to defense against hypoglycemia. Right? Right. Yes, and that's very good that you pointed this out. Pernicious anemia could also be a possible cause for anemia in a type 1 diabetic, pernicious anemia being another autoimmune disease which affects the intrinsic factor. All right, that's very important. Dhananja has asked, how would you calculate dose of sorbitol according to blood sugar level? I will share something with you, but you don't need to know that by heart, Dhananja, so don't worry about that. Nobody knows this by heart. We all refer to something and write it. So there is a formal way of calculating that. I will share it with you. I should have it somewhere. Right? But you don't need to know this by heart, right? Obviously can't remember everything. Talk about, right? So I think now we have basically complete hypoglycemia management. Hypoglycemia management, it's preferred that you use oral correction, right? Oral correction, right? Oral correction of hypoglycemia. If the patient is too ill to receive oral medication, either glucose or some sort of dextrose preparation, then what you prefer is in very profound hypoglycemia to use glucagon, right? Because move away from intravenous insulin, intravenous dextrose, because it's very irritative to blood vessels. So if you have glucagon, you can use it intramuscularly, and that is very effective for severe hypoglycemia. If you are using intravenous glucose, try to stick to 10% and avoid 50% dextrose, because 50% dextrose is extremely irritative to blood vessels. Right? So if you're using intravenous, use 10%. Okay, that is something that you need to know about hypoglycemia. Causes of hypoglycemia, how to manage it. Right. Okay. Diabetic skin changes, you can have a look at some pictures. There are lots and lots, but you don't need to know everything, but the common ones you need to know uh, to identify. Okay. All right. So that's basically about type 1 diabetes. Hari. So any other questions? So I assume that you've all seen that document, Standards of Care in Diabetes. The way that we now start medication is different, or the recommendations are different. And I summarize some of the key recommendations in type 2. Make sure that you look at that guideline, that particular section. And there is some information on type 1 as well in that document. So make sure that you just glance through it. But I think we've covered almost everything you need to know about diabetes. Did Dr. Katlan do a class on diabetes management or Harshad?
No, sir. Diabetes management was not done by Katulanda, sir. Harshad
Okay,
did a class, more class on diabetes management.
okay, that's fine. But we've now covered that in a more comprehensive manner, so there's no problem that you haven't had any input. That's okay. Hari, right. So we just try to do that short case. Then it is actually a bit of a complicated neuro case, but I'll try to sort of explain what we can from it. So what do I need to do now?
So you need to allow screen sharing to others.
Okay,
I'm
so
not sure how to do.
so shall we say I say all participants can share, and
Okay, sir. Now we can share, sir.
okay, right. Can
Gihan
somebody
will
share?
share.
Okay,
Gihan will share
videos.
the videos.
Okay, that's fine. And Malidu has sent me a small PowerPoint as well, which I will share later. Okay, so have a look at this. Okay, hitta nede. Gihan? Small comment, don't call patients amme. Hari some examiners get irritated about that. I don't mind, but some people get irritated. Ammi තාත්ති කියනවා සමහරවිට මල පනිනවා. So don't use that. So you do the pupils, don't stand directly in front of the patient, okay? Just stand slightly to a side.
හරිද කොයි වෙලාවකත් කෑන් දෙකක් දෙට වුණා මට කියන්න ඕනේ හරි කීයක් පේනවද හරි මේ පැන දිහා විතරක් බලන්න එකයි හරි හොඳයි පැන දිහා විතරක් බලන්නේ පැන දිහා විතරක් බලන්න හරි හරි දැන් මේක අයිනෝ වගේ තේරෙනවා නේද ඒ අයිනෝ වගේ තේරුණොත් මට කියන්න ඕනේ ඇස් දෙක පියා ගන්න හොඳට තේරුණාද අයිනෝ වගේම තේරුණාද නෑ දෙකම නැද්ද මේ පැත්ත අයිනෝ වගේම තේරුණා අර මේ විදිහටම තේරුණා නේද හරි ඇස් දෙක පියාගෙන ඉන්න අයිනෝ වගේම තේරුණා මේ දෙකම මේ විදිහටම තේරුණා අයිනෝ වගේම තේරුණාද වෙනසක් නෑ නේද හරි මේ දැනෙනව නේද මේක ඒ වගේම තේරෙනවා නම් කියන්න ඕනේ. ඒ වගේම තේරුණාද? දෙකම තේරුණාද? වෙනසක් තේරුණාද? නෑ නේ. හරි. එතන තමයි අඩුවක් තේරුනේ නේ. හරි. දැන් හොඳට දත් පිටි ගන්න හොඳට. කට හොඳට අරින්න මගේ අතර විරුද්ධව. හරි. හරි හොඳයි. මන්දයා. මේ පැත්ත බලන්න. අපිට අරින්න. ලාවට තව චුට්ටක් අරින්න ඕනේ. තව චුට්ටක් අරින්න. අන්න. තව චුට්ටක් අරින්න. අන්න. හරි. හොඳට රැලි ගස්සන්න. හොඳට රැලි ගස්සන්න මෙහෙම. අන්න හොඳයි. ඇස් දෙක තද කරලා වහගන්න මට අරින්න දෙන්න එපා. හරි. හොඳට ඊ කියලා හිනා වෙන්න. හොඳට ඊ කියන්නේ. තව පාරක් හොඳට කට වහලා හොඳට හිනා වෙන්න. හරි. හොඳට මෙන්න මේ විදිහට කටින් හුලම් පුම්බ ගන්න. හුලම් පිට කරන්න දෙන්න එපා. හොඳට පුම්බ ගන්න. හරි. යටියන්නේ තට්ටිය පෙන්නන්න. යටියන්නේ විතරයි මේ තියෙන්නේ. ඊ කියලා. යටියන්නේ විතරයි පෙන්නන්න. උඩට යන්නේ පෙන්නන්න එපා. බෙල්ල හොඳට රැලි ගස්සන්නන්නේ. ඊ හරි. කියනවා මට මොකද්ද කිව්වේ කියලා කියන්න ඕනේ. කීයද කිව්වේ? දන්නේ නැද්ද? ඉලක්කම දන්නේ නැද්ද නැත්තම් තේරෙන්නේ තේරෙන්නේ දැන් ආ කියන එක පාට හොඳට තව පාරක් හරි තව පාරකම ආ කියන්නේ තව එක පාරක් අර පැත්ත හොඳට බෙල්ල හරවලා බලන්න හරි දැන් මේ පැත්ත හොඳට බෙල්ල හරවලා බලන්න හරි උරහිස් හොඳට උස්සන්න හරි හොඳට කට ඇරලා දිව ඇතුළ කට ඇතුළ තියන්න කට අරින්නම් කට අරින්න දිව හොඳට කට ඇතුළ තියන්න ආ කියලා දිව සාමාන්‍ය විදිහට තියන්න කොෂන් එළියට දාන්න කට ඇරලා එළියට දාන්න හොඳට කට ඇරලා දිව එළියට දාන්න දිව එළියට හොඳට දාන්න දාලා දෙපැත්තට මෙයන් ගන්න
Okay. Right. Hero?
Yes, sir.
All right. Okay, so this is a bit of a tough one, actually.
Yes, sir. Before, can you comment on the technique and the...
Oh, yeah. Hari. I was coming to that. So, කවුද එක්සැමින් කරේ මර මුණ මුකාඩම දාලා පේන්නේ නැහැ මොකක්ද
Rishal sir
right hari මට නම දැනගන්න බයින්නේ so that was good so all in all the examination was okay so මෙහෙමයි at the exam when you judge people or actually mark people you would obviously not see if they are good enough to pass or they're horrible they don't deserve to pass whatever but that's fine your examination was grossly okay there was no major problem with it so that was fine so ara kiwa wage don't call patient the people get irritated about that two is I want to say something when you're doing the cotton wool thing don't sort of do that just touch it and take it off so it's just not sustained pressure it's just light touch when you're doing the cotton wool it's light touch and not pressure right so just just touch it. Don't hold it and pull it down like that. That is something that you need to change when you're doing that. The other thing is, yeah, when you're doing, you don't need to do the corneal reflex routinely, and you don't need to do the jaw jerk routinely. Okay, but the other stuff was fine. Now, if you took that patient, there are several abnormalities in that patient, right? Now, I am going to, for
Sir, one
discussion
more.
purposes,
Hello, sir.
yeah, yeah.
Sir, when taking the visual field, and can we just close our eyes without using the hand?
ප්‍රශ්නේ නැහැ. If you can, but some people can't do that. මේ
Okay.
එකක් වහන්න බැරි අය ඉන්නවා. හරිද? But you don't need to necessarily use if you can do that. Now I can do this without a problem, so you can do that. That's not a problem.
Okay, sir. Thank you.
හරිද? Right. Now this patient has several neurological abnormalities. Now, for purpose of this discussion, I am going to ignore some of the abnormalities. Right. Now, in a short case, if you did this, you would be asked to present your case. Now, there are two things that the examiner asks you. They will give you an option sometimes. Right? They will give you an option. Fine. Would you like to present your findings or would you like to do a diagnosis? Now, often you get these two options. Now, you have to be careful what you select. Now, there are advantages and disadvantages of both. Now, if you're going for a safe strategy, it is always better to present your findings, because you will still get some marks. If you sort of mess up the diagnosis, you will at least get some marks for your presentation, right? So, but if you're really sort of confident about what you're doing, you might say, no, I want to give directly my diagnosis. That gives you more time for discussion, and it also gives you, obviously, the examiner is more impressed. But that's a risky thing to do, because if you mess it up, you won't have any marks at all. එහෙම සම්පූර්ණයෙන්ම fail කරන්නේ නැහැ. මෙහෙම කියලා වුණත් we sometimes go back and ask you to present your findings and try to give you some marks. But I would advise all of you to be safe and sort of present your findings, unless you're really, really confident that when you're sure about the diagnosis and you know very well about that also. For example, if you get cardiovascular examination, mitral regurgitation, you're bloody sure about it. You've read everything about mitral regurgitation and you can just bat on about it for the discussion. Perfectly fine, you say you want to give a diagnosis. But for most cases, it is always safer to present your clinical findings. So that is the first thing that we will ask you. And when it comes to cranial nerve examination, ලොකුවට present කරන්න අවශ්‍ය නැහැ findings present කරනකොට. You can say that, just say right-sided palatal palsy or whatever. You don't need to be overly descriptive about tongue was deviated to the right side. You can give a nice summary of your findings. You don't need to say that you saw facial asymmetry and the mouth deviated to the right. You can say there is an upper motor, lower motor neuron, facial nerve palsy. So that is another misconception that you have that I'm clearing out. You don't need to be overly descriptive about your findings in the cranial nerve examination. Now, for purposes of discussion, this patient has a very, very obvious right-sided or tongue deviation to the right. That is very obvious. Okay? And also patient has fasciculations of the tongue, right? That I think all of you should be able to spot. The tongue deviates nicely to the right side, and there are some fasciculations of the tongue. And so there is a right-sided hypoglossal palsy with tongue fasciculations. And there is also a palatal palsy. පොඩක් ළඟට ගිහිල්ලා බැලුවොත් I think it should be left or right එක පොඩක් බලන්න ඔයගොල්ලෝ වීඩියෝ එක බලලා. There is a palatal palsy also, but that's a bit more subtle, difficult to detect. Now there are some other things to facial එකේ පොඩි මේකක් තිබුණා, sensory loss එකක් තිබුණා. Though when you put those things in, it becomes really difficult, right? So I'm just going to ignore those, right, for the moment. So basically this patient has tongue fasciculation. Has a right-sided hypoglossal or a 12th nerve palsy. Remember that the tongue always deviates to the side of the lesion. So that is a hypoglossal palsy, fasciculations of the tongue, and also palatal palsy. What side hiru මොන පැත්තේ palatal palsy තිබුණේ? Left the right? I think it was
Right, sir, right.
Right side.
Deviated to the left side.
Yeah, so there's a right-sided palatal palsy as well. and a right-sided hypoglossal palsy and fasciculations of the tongue. Hari. So that is what you have. I'm going to ignore the other abnormalities because it becomes a bit difficult when you put those in. And definitely, I wouldn't expect an undergraduate to discuss it to that level. So I'm just going to forget those. Yeah. Well, I'm just going to forget those for the moment. You need to think in neurology, as I told you when we were talking about neurological examination, there are two questions that you need to answer. First question is, where is the lesion? Second question is, what is the lesion? Now, if you ask the question, where is the lesion in this patient, right? So you have a patient coming with a palatal palsy and a hypoglossal palsy. Now just take a little bit of time to think this out. You know that the palate is supplied by your 9th and 10th cranial nerves, right? And the tongue is supplied by the 12th cranial nerve. So this is a lesion of the 9th, 10th, and 12th cranial nerves. I assume, Hiru, that the 11th was normal and you didn't find any
Yes, sir.
sternocleidomastoid
11
waste.
was normal, sir.
Okay.
Normal.
Hi. Now you need to think of where do these cranial nerves lie together. That is very important. So these cranial nerves lie together. This could be a central lesion. Okay. So 9, 10, and 12. Where do these lie together? They lie together in the brainstem. That is a central point, specifically in the medulla. Okay. So you need to ask yourself, could this be a central lesion of 9, 10, and 12? Central, where the lesion is inside the medulla. Or could this be a more peripheral lesion of these cranial nerves along their course? Okay, along their course. Right. Now, if this was a central lesion, okay, if this was a central lesion, you would expect the patient to have certain features. Okay, if this was a more central lesion, you'd expect the patient to have certain additional features of other structures inside the brainstem. Okay, specifically the medulla, cerebellar involvement, plus Horner syndrome, because the sympathetic trunk or the sympathetic fibers pass through the medulla. Okay, so you'd expect the patient to have, if this was a central lesion, expect the patient to have cerebellar signs, or you'd expect the patient to have significant the Horner syndrome, right? Nystagmus, because you know that the vestibular nuclei and all of these are in the packed inside the medulla. So nystagmus, cerebellar signs, Horner syndrome, something like you'd get in lateral medullary syndrome. So these are the features that you'd get if it was a more central lesion. Now the fact that this patient doesn't have any of those signs, doesn't look ataxic, and I didn't see any nystagmus in your examination, indicates that this, and added to the fact that the patient has fasciculations, indicate that the lesion is somewhere beyond the center. It's not in the medulla, but it's somewhere beyond, in the peripheral course. The fasciculations indicate that it is more of a lower motor neuron, so you're dealing with a more peripheral disease, a more peripheral disease. Okay, so 9, 10, and 12 in a more peripheral disease. We saw that the fasciculations are bilateral, but the other findings are more towards the right side, right? So that is a first step in working it out. So if, say, these lower cranial nerves, could this be a central lesion or could this be a peripheral lesion? If it was a central lesion, you'd expect nystagmus, you'd expect cerebellar signs, you'd expect Horner syndrome, all of these signs to be present, but they were not there. The fact that the patient's fasciculations and the absence of central signs indicates that this lesion is possibly somewhere in the course of the cranial nerves as they go out of the medulla the vein within the skull, right? And remember, as they cross these foramina, they go through the meninges. So that is possibly where the lesion is, right? So it is in the course of the cranial nerves as they cross through the cranial fossa and exit the skull. Okay, and this is all at the base of the skull, all at the base of the skull. So it is likely that the lesion is somewhere there. Okay, and what is the etiology? So these lesions can be due to various etiologies. The common things are things like a nasopharyngeal carcinoma that infiltrate into the cranial nerves as they go through the uh, cranial fossa and enter this skull foramina. Okay, so nasopharyngeal carcinoma. Remember that these cranial nerves, because they cross through the meninges, anything that causes a basal meningitis like tuberculosis can be affected in any of these diseases. Thirdly, anything that infiltrates these cranial nerves as they go into the skull foramina, any infiltrative disease like Wegener's granulomatosis, for example, right? They infiltrate into this foramina or sarcoidosis, right? These things can also cause these lower cranial nerve palsies, peripheral type lower cranial nerve palsies. Okay, so that's what you need to talk about. But I would say this case is a bit too much for you guys because of the fact that the patient have other problems scattered around and you might get utterly confused, right? So, but if you, for teaching purpose, I've ignored them. I have just focused on the key results of the hypoglossal palsy. You work that out. So these are, you classify them on the common theme, lower cranial nerve palsy. Ask yourself, could this be central or could this be peripheral? If it's central, you might get certain things, right? You don't have these in this patient, and additionally, the patient has fasciculations of the tongue. So this is probably a more peripheral nerve disorder. Common causes of peripheral nerve disorders are infiltration due to processes like nasopharyngeal carcinoma and other infiltrative diseases like Wegener's granulomatosis and sarcoidosis. So that is basically it. Any questions? Peter, mic on kala handane uchara me baya wenna deyanne naha. Hiru, I think this is a good idea. If we can get a few videos, we can do a lot of
Okay, sir.
neurology using this, but make sure that you get some good. This is a complicated one. I appreciate that you videoed this and the examination was done nicely, but it's a bit complicated for your purposes. මේ මොකද
Yes,
මේ වගේ
sir.
ටිකක් අමාරුයි. මේ clear cut නැහැනේ. මේ
Yes, sir.
හොඳටම
This
obvious.
was the only patient I could find, sir.
Oh, neurology wards වල තියෙන patient.
Oh, neurology wards කියා
වැරුණාද?
නෑ low limb case එකක් තිබ්බ sir. ඒක වීඩියෝ කරා ඒක උනට ඒක අර මේ මයෝපති එකක් වගේ තිබ්බේ. තව cases තිබ්බා ඒක මේ කලින් වීඩියෝ කරන්න consent දුන්නේ නැහැ sir. සමහර කට්ටිය. ඔව් sir.
බලන්නකො තව
තිබ්බ sir I will case
පොඩක් කොහොම බලන්න මොකද අපිට මෙහෙම ඩිස්කස් කරන්න පුළුවන් ටිකක්. උගලට එක්සෑම් එකට එන જાතියව වීඩියෝ කරගන්න මේ වරන් ටිකක් අමාරු මේකට ඇත්තටම PG කේස් එකක්. මේක PG ට දුන්නත් අනිවාර්යෙන් නා ගන්න ඕන. මට හිතෙන විදිහට මේක ඉතුරු ඒවා ටික දැම්මම මේක ප්‍රොබ්ලම් මොකක් හරි බ්‍රේන් ස්ටෙම් ප්‍රොබ්ලම් එකක් වෙන්නේ නැති කියලා මොකද ඔය අප්පර් මොටර් නියුරෝන් ෆේෂල් එකක් එහෙම තියෙනවා. මේ හැබැයි ඒව දාගන්න කිව්වොත් එහෙම කොට අමාරුයි. ඒකයි මම මේකට ලිමිටඩ් ඩිස්කෂන් එකක් කරේ. පල්ලෙහා ටික විතරක් ගත්තා. මේ හැබැයි ඔබ්වියස්ලි ටෝසිස් ඒවයි කොමන්ලි දෙන ඒවා අපිට හොඳට කතා කරන්න පුළුවන් එකයි. මේ නියුරෝ වලට ඇත්තට මේක හොඳ සිස්ටම් එකක්. remotely කරන්න පුළුවන් ක්‍රමයක්.
Okay, sir. I'll try to find. The problem is, sir, I don't think we are allowed to
go.
Furthermore,
yeah, man, දන්නේ නැහැ බං මොන වදයක්ද කියලා මේ කොරෝනා වෛරස්.
I'll try to find, sir. Anyway.
බලමු කරන විදිහට කරමු. නැත්නම් මේ කොහොමදත් මේ මගුල් ටික වෙලා එක්සෑම් එක ලඟ වෙලත් මේ විදිහට නියුරෝ ටිකක් කරන්න පුළුවන්. මේ විදිහට අනිත් ඒවා කරන්න බෑ obviously. ඔස්කාර් ටේට් කරන්න බෑ. ඉතින් මේ remotely නමුත් නියුරෝ ටික කරගන්න පුළුවන් මෙහෙම මේ එක්සෑම් එක ලඟ වෙලා වුණොත් උඹට අපොයින්ට්මන්ට් එකේ බැරි වුණා.
හරි සර් හරි.
හරි එහෙනම් අපි දැන් මොකද කරන්නේ? එතකොට අපි දැන් හෙට ඉඳන් නිකන් කාඩියෝවැස්කියුලර් එහෙම කේසස් ටික කරමු.
හරි සර් හරි.
හරි. right. okay. අද ළමයි වැඩි මේ වෙන ගෲප් එකක් කට්ටියක් දිනවද?
ඔව් සර් මේ වෙනදා මේ සර්ජරි දැන් මේ දවස්වල සර්ජරි කරන කට්ටියට මම ලින්ක් එක යවනවා සර්. ඔයගලන්ට මේ සර්ජරි රැයටත් යන්න ඕන නිසා අනිත් දවස්වල මේ එන්න බැන්නේ මම හිතන්නේ සර්.
හරි හරි.
ඕකේ සර් අද නිවාඩු නිසා ගොඩ කට්ටිය
ඇවිල්ලා. හරි. ඕකේ. හරි එහෙනම්.
හරි සර් thank you.
හෙට අපි විතර හෙට ඉඳන් කාඩියෝවැස්කියුලර් රෙස්පිරේටරි හැම කේසස් ටික නිකන් කරගෙන යන ෂෝට් කේසස් ටික ඩිස්කෂන් පොයින්ට්ස් ටික.
හරි සර් හරි.
හරි. okay right.
Thank you sir.
Thank you.
හරි. okay.
Thank you, sir.
Thank you, sir.
Thank you.
Okay.
Thank you, sir.
Thank you, sir.
Bye.
Thank you, sir.
Bye.
Bye.